Hello students, today's class is an introduction to the cysts of the oral and paraoral region. It will be covered under the following headings: definition, parts of cyst, classification, location, etiology and origin in general, and the diagnostic features. Cysts are the most common benign destructive lesions, and the definition is a cyst is a pathological cavity having fluid, semi-fluid or gaseous contents and which is not created by the accumulation of pus. Frequently but not always is lined by epithelium. This definition was put forth by Kramer in 1974. The word cyst is derived from the Latin word cystis, in turn, which is derived from the Greek word custis, meaning bladder or pouch or sac, which is typically filled with liquid. The parts of a cyst are: you have in the center a cavity which is called as the cyst lumen and which is surrounded by a lining which is nothing but the epithelial lining, and which in turn is surrounded by the cyst capsule which forms your connective tissue wall. The presence or absence of the epithelial lining dictates whether the cyst is a true cyst or whether it is a pseudocyst or a false cyst. The cysts are broadly classified into epithelial cysts and non-epithelial cysts. The epithelial cysts, which are the true cysts, are further classified into odontogenic and non-odontogenic, and the odontogenic further into developmental and inflammatory. The developmental odontogenic cysts, you have odontogenic keratocyst, dentigerous cyst, eruption cyst, gingival cyst of infants and adults, the lateral periodontal cyst, the botryoid odontogenic cyst, the calcifying epithelial odontogenic cyst, and the glandular odontogenic cyst. Under inflammatory odontogenic cysts, you have radicular, residual, and the others. In developmental non-odontogenic cysts, which are called as a fissural cysts, you have the nasopalatine duct cysts, the nasolabial, the mid-palatine raphe, and the others. The non-epithelial or the pseudocysts are the aneurysmal bone cysts, the solitary bone cysts, and the Staphnase cavity. The benign mucosal cyst of the maxillary sinus and the surgical ciliated cyst of maxilla both are the cysts of the maxillary sinus. Cysts of the salivary glands comprise of mucocils and the ranula, and you have a list of other cysts ranging from dermoid cyst till the gastrointestinal cyst. Well, in the WHO classification 2005, the parakeratinized variety of the odontogenic keratocyst and the calcifying odontogenic cyst both were considered as cystic neoplasms and renamed as keratocystic odontogenic tumor and the calcifying odontogenic tumor, and included in the category of odontogenic tumors arising from both odontogenic epithelium and ectomesenchyme. But in the 2017 classification by WHO, it was revoked back and the parakeratinized odontogenic keratocyst was named as odontogenic keratocyst, and the orthokeratinized odontogenic cyst remained as a separate entity, and the calcifying odontogenic cyst was again put back to odontogenic cysts. Most of the cysts of the oral region, you find they are present within the jaw bones, that is intraosseous location, whereas a couple of cysts arise in the soft tissues which are called as the extraosseous ones. Most of the cysts have an unknown etiology, and however some may have an etiology of trauma, or it could have arisen from an inflammatory process or probably following an embryonic defect. Most of these intraosseous jaw cysts have invariably an odontogenic origin. May it be the remnants of the dental lamina, the reduced enamel epithelium, or the enamel organ itself, or the cell rest of malas, or even the basal cell layer of the oral epithelium. So, depending upon the origin of the cyst from the different parts of the enamel organ or from the different remnants, we have different cysts. The non-odontogenic cyst, usually they arise from the remnants of the epithelium at the lines of closure of various facial processes. The soft tissue cysts arise either from the ducts of the salivary gland or the thyroglossal duct, or sometimes they can be remnants of the embryonic skin or the entrapped epithelium from the lymphoid tissues. Accordingly, the names of the cysts are derived from the origin. Well, how do we come to a diagnosis of a cyst? So it is all based on the findings of your clinical examination, followed by a list of investigations, right, starting from the vitality test, the radiograph, the aspiration, the biochemical evaluation of the aspirate, the macroscopic examination of the aspirate, or you can even do a cytosmear of the aspirate and record the cytological findings, and the final diagnosis comes from the histopathological findings, which is recorded after performing a biopsy. In the clinical findings, you find that most of the cysts, they occur as expansile swellings associated with either a missing non-vital or extracted tooth, or sometimes they may present with just a salty discharge with or without a sinus. At times, they can be even asymptomatic, in which case they'll be discovered during an they're accidentally discovered during clinical examination or probably on a radiograph. Sometimes the patients pose with teeth problems, either retained teeth, missing teeth, or displaced teeth. And most of these cysts, you find they have an intraosseous or a soft tissue location. So you have to know whether the cyst is within the jawbone or whether it is located in the soft tissue. If it is in the soft tissue, the cysts may be either superficial or they may be deeply located, in which case the color of the overlying mucosa plays a very important role. If the color is blue, it usually gives a clue that the underlying swelling could be a mucocele. But sometimes, due to secondary hemorrhage, it can appear even red too. Most of the cysts appear as painless swellings, and if the pain is present, it usually indicates that the cyst has ruptured or has been secondarily infected. Needless to say, most of these cysts are well defined swellings. They may either be as appear as fluctuant swellings or they may be soft in consistency depending on the contents of the cyst. Most of these intraosseous cysts, you find they have a specific location. Like if you take the fissural cysts, they have a specific location. A dentigerous cyst, usually you find it will be associated with impacted teeth, and odontogenic keratosis occur in the mandibular posterior region. Solitary and even the Staphylococcus cysts all occur in the mandible, and a radicular cyst, you find usually it will be associated with a non-vital or a carious tooth with pulpal involvement. History of extraction plays a very vital role in diagnosing a residual cyst. And the clinical absence of the teeth, either from the normal series or sometimes it can be even a supernumerary tooth, is usually indicative of a dentigerous cyst or a odontogenic keratocyst. In the initial stage, you do not find any clinical manifestations, and most of these jaw cysts are discovered accidentally on radiograph. Well, with time, you find the cortices start expanding. Initially, it is the buccal, followed by the lingual plate, and it leads to a smooth, hard, and a painless swelling. Exception is the OKC because this cyst spreads along cancellous spaces, and expansion is a very late feature in OKC. Later on, as this cysts go on expanding, you find the bone, the cortical bone gets thinned out, and on palpation, you can elicit a tennis ball consistency or what you call as a ping pong ball effect. With further resorption of the bone, you find it becomes more thinned out and it becomes fragile and it fractures under pressure. And this gives rise to an eggshell crackling effect. With the complete resorption of the bone, you can elicit the fluctuation. Sinus formation can sometimes follow after the resorption of the bone, or sometimes it may get infected as it starts communicating with the oral cavity and it becomes painful, emanating a foul discharge. The large cysts usually cause loosening of the teeth and even pathologic fractures, and they may also involve the inferior alveolar nerve, leading to paresthesia. They may cause divergence or convergence of the crowns, or if they are located in proximity to the maxillary sinus, you may find the patients they come with the symptoms of sinusitis and you can elicit signs of sinusitis. Or if it's involving the nasal floor, it may lead to distortion of the nostril. So depending on the location you find, you get varying signs and symptoms. The next in the is the investigation. So in the investigation, the first part is you do a vitality test followed by an X-ray. So on the radiograph, you find a cyst usually appears, that is a classic appearance of a cyst on a radiograph is a well-defined unilocular radiolucent area which is round or ovoid, very well circumscribed by a sharp radio-opaque margin which you call it as a sclerotic rim. But at times you find the differences, they manifest in varying ways. Like you have the traumatic bone cyst, which usually you find the scalloped margins in case of a traumatic bone cyst. Sometimes, like in case of dentigerous cyst, invariably you will find the radiolucency which is around the crown of the impacted tooth, like as you see in the radiographs over here. But sometimes even a OKC can occur in relation to an impacted tooth and may push the tooth to one side or to the edge of the radiolucency. So in that case, you have to be careful with the diagnosis. So it could be a dentigerous cyst or could be a OKC. The periapical cyst or the radicular cyst occurs in a periapical location, as you can see in the picture, and this tooth is treated, the root canal has been treated, and you find the hazy margins instead of a sclerotic rim. So this indicates that the cyst is infected. Sometimes you may find a small radiolucency between two roots, and this is usually indicative of a lateral periodontal cyst or could be even a radicular cyst of the lateral variety. A nasopalatine duct cyst has a classical radiographic picture, that is a heart-shaped radiolucency. It occurs between the two upper maxillary anteriors, and this heart-shaped is caused because of the impingement of the nasal spine. Instead of a single radiolucency, the cysts sometimes they may appear as multilocular radiolucencies. Like as you see in this radiograph, there are multiple locules of radiolucency. Or this is usually indicative of either the daughter cyst or the multicentric growth pattern of the cyst, and it is usually seen in case of a odontogenic keratocyst. If a cyst becomes aggressive or starts expanding rapidly, you find the radiolucency, instead of becoming regular, it will be irregular and will have a scalloped or a lobulated margins. It will cause resorption of the roots as you are seeing in the radiograph, and also it will displace the inferior alveolar canal, and in this case you can see the impacted tooth has been pushed down to the inferior border of the mandible, probably causing even a fracture of the inferior border of the mandible. All this is, you find they usually do not cross the midline. The exception is a OKC. The next investigation you do is a FNAC. Now once you do a FNAC, you draw the liquid and this confirms the cystic nature of the swelling. And usually for such an aspiration, you go ahead with a wide bore needle, that is 18 gauge needle with a 5 to 10 ml syringe. Now once you aspirate the fluid, the examination of the aspirate can again give clues to which type of cyst it could be. Suppose you find a cheesy cream thick fluid on aspiration. It is indicative of a odontogenic keratocyst, as you can see in the pictures over here, and here you can find the radiograph also, wherein, as I said, this tooth is pushed to the edge of the radiolucency. So OKCs can also have this dentigerous cyst like appearance, but here you find there is extensive destruction of the mandible. And on aspiration you're getting a cheesy aspirate. Sometimes you may get even a straw colored aspirate. This straw colored aspirate is usually indicative of a dentigerous cyst, or it can be even a radicular cyst or a lateral periodontal cyst or even a residual cyst. And if you find some glistening crystals in the straw colored fluid, it is indicative of the cholesterol crystals. And this straw colored fluid, sometimes if you have gone through a blood vessel, it can be blood tinged. So you may get a straw colored fluid which is slightly blood tinged, as you are seeing in this photograph. When you aspirate a golden yellow fluid which clots on standing, it is indicative of a solitary bone cyst. Aneurysmal bone cysts and some vascular tumors or even a solitary bone cyst, you can find on aspiration it yields fresh blood. That is, you get a bloody aspirate from these cysts. So this is a photograph wherein they have drawn the aspirate, blood aspirate from a aneurysmal bone cyst. If the aspirate is usually cream or greenish with foul odor, you find it is indicative of an infected cyst. And in this case, you find it's a radicular cyst. They have aspirated and the pus is mixed with blood. Sometimes you may get a hemorrhagic fluid which is completely red in color, or it can be dark brown in color as seen in these photographs. It is usually indicative of either a vascular lesion, or it could be a fresh hemorrhage which has occurred in a cyst if it is red, and if it is brown it is usually indicative of an old hemorrhage which has occurred in the cyst. The aspirate further can be sent for biochemical evaluation. And in the biochemical evaluation, usually the levels of soluble proteins are estimated, and to some extent even the immunoglobulins, glycosaminoglycans, and even the antigens. Now, if the level of the soluble proteins crosses 5 gram per 100 ml, it is indicative of an inflammatory or a non-keratinizing cyst. And if it is less than 4 gram, usually you find it is a keratinizing cyst, because the keratinized epithelium won't allow, or rather doesn't permit, the flow of the albumins and the globulins. Hence you find the soluble protein levels will be always less. With the smear further, you can do a cytosmear and record the cytological findings. Now on a cytosmear, if you get to see these keratin or parakeratin squames, it is usually indicative of a odontogenic keratocyst. And if the cyst is having these cholesterol crystals, they appear as plate-shaped crystals, rectangular in shape, which are piled up on each other with broken edges. And apart from that, you can see a lot of RBCs, inflammatory cells, debris, and the epithelial cells. However, with the cytological findings, you cannot arrive at a conclusive diagnosis, but to some extent, like OKC and all, you can think that of a, you can rather come to a diagnosis. The biopsy, however, gives you the final diagnosis, and a specimen which is sent is recorded both on macroscopically and microscopically. So the macroscopic findings of the specimen usually confirms the cystic nature. As you can see in the photograph, here you are finding a cystic lesion along with the tooth which is covering the crown of the tooth. So this is definitely indicative of a dentigerous cyst, because you can find it is attached to the neck of the tooth. Well, even it can be a follicular variety of odontogenic keratocyst also. Hence, you have to go ahead and cut open the specimen and record the histopathological findings. Then the second is you can have a look at the contents of the cyst. So most of the times you find it will be empty, or sometimes you may find whitish squames which are indicative of your OKC. You can also record the thickness of the capsule and the attachment of the cyst in relation to the tooth, and if any luminal proliferations or nodules are present. Then you go ahead and cut out the specimen bits and process it, and then you make it into a slide, and on the slide, through the microscope or using a microscope, you record the microscopic findings. Now this gives the final diagnosis of the lesion. So in the microscopic findings, you record the luminal contents, and if there is a epithelium, what type of epithelium is it, and what is the thickness, whether it is continuous, broken, or whether there is any ulceration, exocytosis of inflammatory cells, you find any abscesses within the epithelium, etc. are recorded. And the connective tissue capsule, usually you find there will be parallel collagen fibers in the capsule. So that is indicative of a capsule. Apart from that, you also look for any cholesterol crystals, as you are seeing in this photograph, which appear like needle-like spaces surrounded by multinucleated giant cells and hemorrhage. And also you look for any odontogenic remnants or probably epithelium buddings, etc. And in the last, you give a diagnosis. So that is the final diagnosis of what type of a cyst it is. So depending on that, the further treatment is carried out. Thank you.